My bias is I'm not a radiologist, so I will talk about CT scan and MRI from I lost the slide again. From a clinical perspective. May I have the slide on? Okay, fine. So in the next minute, I will talk about the role in diagnosis, assessment of activity and severity, assessment of complication, evaluation of response to therapy, and measure of structural damage. So don't forget the traditional investigation, but use very cautiously, because if eventually have some role in few patients, they are for sure overweight now by the beauty and the efficacy and the accuracy of the other imaging I will talk about. And also don't forget about the radius position. So we have great imaging with small bowel enteroclysis, but we got 24 millisievert. So 3 millisievert is the exposition of 1 year. And so look how eventually frequently these patients should have investigation during their life and keep, be very careful about the accumulation of radio exposition. Less from the barium fall through, but there also the kind of accuracy that you can get is very limited. So if you go across the cross-sectional imaging, even there, keep attention to the radio exposition. You have a very fancy multi-slice TC enteroclysis. You feel all the details there, but you have 11 millisievert of radio exposition. If you go to entero-TC, you reduce quite a lot. If you go to enteroclysis, great definition even there, but you need some radio exposition to position your catheter. And probably most of the case, entero-RM is quite enough, no radiation, very good efficacy. I summarize the most important statement of the last ECHO guideline regarding the radiology. First of all, it's perceived the ultrasound is very much operator dependent. But to have a good evaluation of CT scan, of CT, entero-CT and entero-MR, you need to have at least an experience for 10 very well investigated studies. Because it's very frequent from every one of us, probably we have seen patients with description of thickness of the terminal ileum without the ileoscopy, and there is nothing there. So simple contraction. So it's very important also from radiological point of view, there should be experience there. And importantly also, in terms of radio exposition, we have to limit the utilization of CT scan only in kind of emergency or in terms of complication. So what to do is doing better. There is no difference there. You see in this forest plot, there are not many kind of update in the literature because the methodology are quite established there. You see in terms of evaluation of activity, evaluation of complication, not quite a difference if you compare the CT with the MRI. But indeed, MRI and CT as well has some limitation. The proximal part on the small bowel, in this case, still, at least for the evaluation of mucosa, the small bowel capsule endoscopy can achieve more information, although even there should be taken cautiously. 2, 3 after probably doesn't mean anything, and it should, I've seen quite a lot of cases over-treated for Crohn's disease which is not there. So if we look to the accuracy in terms of evaluation activity, as has been stated already, there is not quite a lot difference among US CT and MRI in terms of sensitivity and specificity. And the difference on MRI that you can have compared to the ultrasound, a grading of activity, and of course also to evaluate what is also outside the small bowel in terms of complication, looking for example for fat straining, which is not something that we can evaluate with ultrasound. It's probably something also relevant in terms even in pathophysiology of IBD. And if we look to the assessment of lesion, once again, you see in terms of wall thickness has been stated that 3 millimeters is the threshold. You see probably US is doing even better than CT scan. And if we also add contrast enhancement on US, you can have pretty much the same evaluation also compared to other methodology. And the same can true for the stratification. Unless for other parameters, like for ulceration, you see better with MRI, lymph nodes, you see better with the cross-sectional imaging, and the same also for vascularity and complication. Now, as I said, very nice evaluation of presence of edema, and eventually you see also the very clear correlation of the endoscopical and the MRI imaging of the presence of ulcer of pseudopolyps there. So if you like to be more accurate, and this is more relevant in clinical trials, you can evaluate a score. It's a bit troublesome, but with a bit of training, you can have this kind of MRE score that was proposed by the Bar Barcelona group. And you see there is quite a good correlation with the endoscopic evaluation of this patient. This is relevant in the follow-up of patient, especially in control trial. So accuracy across complication, look in the fistula, you see probably a bit more for MRI there, but not quite a great difference in terms of specificity. If you look at the images, is very nice also the comparison with the anatomical relevance of the presence of enterotic fistula in this case. If you look to the abscess, once again, probably a bit more with MRI, but there is not a significant difference in the good eyes, I will say, not too good ends for ultrasound imaging. And this is another sample here of pressure and fistula and abscess. Once again, you can see also the very nice correspondence to the anatomic evaluation. Once again, for stenosis, you see there is no clear difference in terms of sensitivity and specificity. This was a review done years ago by Panes and among the three methodology. And once again, you see here the very nice picture of stenosis here. And if you look, the anatomical picture there is quite amazing. Now, probably the great beauty of MRI compared to all the other methodology, compared to CT scan and ultrasound, is the evaluation of the pelvis in terms of the evaluation of perianal fistula. This is the standard of care in terms of evaluation, is the most accurate imaging modality, and it is the best way also to follow up the patient. So eventually, for the ultrasound, can be done externally, a kind of perianal ultrasound, but cannot be such deep and such topographically defined as MRI. So that's the way to do. We know that Crohn is a transmural disease, so we know that probably evaluation of inflammatory marker and mucosal leaning can be not enough, and probably we will move to, especially when we may, in patients with early diagnosis, early treatment, to also to have a complete healing of the wall. And there are some data, this is one, that are accumulating. You see that eventually, in terms of surgery, there is not clear difference if you evaluate patient without or with mucosal healing, while there is a difference if this patient have in green a completely, so that's my fault. Every time I speak, there is something with the projector, so there is a kind of electrical feedback. But we're almost at the end, again, there, and so it's quite clear if you follow the green line when you will see it, those are the patients with complete transmural healing with MRI. There is a clear separation also compared to endoscopic healing. So again, probably we have to move in that, especially in the patient we can achieve early. Of course, you would like to wait the small bowel damage in general, the bowel damage. This is the Lehman score. That's the best ways to do an MRI. It's a bit, cumbersome them. And once again, in the control trial and in comparison among the efficacy of therapy, it can be important. And you can see very nicely the evolution during the year of the efficacy of the treatment when it's there. So I keep very short, and because we have a bit little time, and these are my keynotes. So basically for diagnosis, for the assessment of activity, for the evaluation of response of therapy, for the structural damage, and for the pelvis, MRI is the way to go. CT just remain to use for the complication. Thank you for your attention.